Several years ago in 2019, I developed a mechanical joint derangement in my left shoulder. And I remember the case clearly. I was studying on my stomach, propped up on my elbows a lot on my bed for the MDT diploma. MDT is Mechanical Diagnosis and Therapy. Some people call it the McKenzie method, but really it's Robin McKenzie's contributions to orthopedic care, which delineate a diagnostic test, repeated movement testing, and a treatment protocol, repeated movements, if the diagnosis is a mechanical joint derangement. This is in contrast to problems in orthopedics such as tendinopathies, or muscle or ligament problems, or structural or degenerative problems. And I agree with Robin McKenzie's thesis that most orthopedic disorders are mechanical problems in joints, meaning joints aren't behaving well. I call them tweaked joints. But they present with signs and symptoms that are different for different people. But by definition, if you have the affected joint and you move it repeatedly into the specific direction it needs, all those signs and symptoms, whether they're loss of strength, nerve tension, referred pain, local pain, all those signs and symptoms will by definition resolve in order for this phenomenon to meet the criteria of a mechanical joint derangement. But since I was studying a lot on my shoulder, that was a new force through my body that I was not used to. I made sure through simple testing of repeated movement testing of my neck and my mid-back that my shoulder complaints were not coming from the spine, and they weren't, so I deduced it was a shoulder joint derangement and proceeded to fix it with some simple repeated movements. Now, one point in this episode that I want to highlight is acute loads or cumulative loads through joints can create joint derangements. And this was a new load through my joint. It was a new position, new weight bearing, prolonged sometimes for hours a day in that position. And that's what contributed or actually caused the mechanical problem in my shoulder. Now, I think what I really find intriguing is that what other problem could this be if that was the predisposing factor, is lying propped up on elbows on your bed for several hours a day for weeks. What else could that contribute to? It's not going to create a muscle problem. There was no real load through my muscle, especially someone who has a relatively strong upper body. There wasn't much of a load through a muscle or several muscles. There wasn't much of a change or strain to ligaments. It wasn't a big, yes, it was affecting structures because obviously structures make up joints, but it doesn't make sense that doing that relatively innocuous load, even though it's new, it's not that forceful, would contribute to structural compromise, meaning that the labrum is torn or a tendon has been torn. So in orthopedics, a lot of people are diagnosed with structural problems. A lot of people are diagnosed with muscular problems, whether they're tight and or weak. And a lot of people are diagnosed with kind of these ideas like shoulder impingement syndrome that are, to me, don't really hold up. They are kind of these vague ideas about how multiple things fail at once, and therefore treatment needs to affect several, 5, 6 or more things at once, like strengthening and stretching and stabilizing and massaging tissues and lots of different modalities. So if we think about the cause, I was lying on my elbows, propped up on my stomach, and now all of a sudden I developed shoulder pain in that position, and then that shoulder pain crept into daily life to a minimal extent. It was never excruciating or really limiting, but we have to think about, well, diagnostically, what could that be? And most people, most clinicians do not have this idea in their heads that it could be something with a misbehaving joint. It could be that the joint mechanically had a new load through it and it just wasn't up to the task. Obviously, my right shoulder did fine with that new load, but the left shoulder for some reason didn't. So if they don't have that idea that maybe a joint is just a little tweaked, then they have to diagnose something else because this is not in their recipe book. It's not a possibility. So when I do my self-assessment, another interesting point, which, kind of really, again, emphasizes that this is a joint problem, a mechanical problem of movement, is that I had loss of motion in several planes, including flexion, abduction, and functional internal rotation, maybe horizontal adduction. I don't quite remember the details about that. But what is striking to me is I do recall very clearly that my shoulder abduction was limited, but it wasn't painful. And that's just something you don't really pick up on until you, as a clinician, really start to focus on it. And then you start to realize, wow, well, there's no pain or tightness stopping this joint from moving. It just doesn't move. So looking through that lens, you can really start to understand again, well, what could that be, right? It's not a tight tissue. It's not a tight muscle or tight fascia if the patient doesn't feel that tightness as the contributor to the restriction or the lack of mobility. For me, it didn't even hurt. It just didn't go. And I thought that was so interesting that all of a sudden I would lose 20 or 30 degrees of abduction, but it wasn't due to pain. So I self-assessed and I fixed it over the course of days to weeks with some repeated internal rotation up the back, I think, possibly some repeated horizontal adduction across the body. All I know is it resolved pretty quickly with some simple movements of the joint, mechanically moving the joint into the direction it needs to get back on track, so to speak, not strengthening, not stretching, not stabilizing, no modalities, And that, therefore, is the definition of a mechanical joint derangement. If you can fix it and restore it to normal with simple movements in a specific direction or two. In the extremities and in the spine, sometimes it's more than one. Usually it's just one. And as I've gotten better at treating extremity joints using mechanical diagnosis and therapy, it's possible that now I would have approached that shoulder more efficiently than I did in 2019, given that 5 or 6 years have gone by in terms of my use of MDT in the extremities, not just in the spine. So I think that's a really interesting point, is that there can be obstruction of a joint without pain. And that, as one data point in the clinical decision-making process regarding diagnosis, is really important because it rules out a lot of things if it just doesn't go, but it's not painful. Thirdly, another point about this case is that I haven't really thought about that shoulder since. Yes, as part of my workout routines, I regularly, many times per week, take my shoulder to end range in all different directions, which takes just a few minutes. I reach all the way up the back, for example, all the way across my body, all the way into flexion, all the way to extension, all the way into abduction. Sometimes I do circles with my shoulders. I want to keep them mobile, but it's never come back. It's never been something I've really been concerned about. Like, I would never think to myself, oh, I can't lie on my stomach propped up on my elbows, although it would be a rare scenario where I'd have to do it several hours per day for weeks, which is what I did back in 2019. But it would never scare me that it would come back, because if it did, I would know, oh, it's the mechanical joint derangement again. Let me just fix it with some simple movements. So I think that is an important part to understand too, is that extremity joint derangements, in my experience, don't tend to be something that people have to kind of really focus on going forward in their lives. And I think that has to do more with the fact that the creation of the derangement is a more kind of acute force, or a relatively new force, like in my scenario, versus a lifestyle force. In the spines, however, I think a lot of these mechanical problems are coming about due to lifestyle, and they're kind of building over years to decades, and therefore reversing them and maintaining them requires more of an approach that thinks about lifestyle and thinks about keeping that spine mobility on a daily or weekly basis, and doing some exercises for maintenance that is appropriate for the individual. Maybe it's once a day, maybe it's twice a day, maybe it's once a week, maybe it's only when you do movements in the other direction. So I think you need to be more on top of those types of things, simply because they are a byproduct of your typical life. Whereas if you get hit in the shoulder, if you do what I did and have a new load through the shoulder for a couple of weeks, those things, once you reverse them, don't seem to plague people down the line or recur to the same extent as those in the spine. So shoulder joint derangements are, to me, fun to treat. As I've done videos before, we commonly find that moving up the back into functional internal rotation, or moving across the body into horizontal adduction, or moving backwards into extension, tend to be the repeated movements that most people, or most patients, will need one or more of those versus other movements such as flexion. But there's a couple of videos that I've highlighted on YouTube that talk about this, and other clinicians have posted some videos too about shoulder derangements. Like I said, to me, they're kind of fun to treat, and they're not that hard once you start to recognize them. The problem is a lot of shoulder complaints are coming from the spine, so we must be thorough and use repeated movement testing if safe in the neck and or the mid-back, to make sure that that's not where the mechanical problem is, and that the spine is not referring symptoms to the shoulder or creating problems in the shoulder and signs in the shoulder as well. But if you rule out the spine, then we can start to think, well, is the shoulder problem a mechanical joint derangement? Again, that's in contrast to a labral tear, or a tendinopathy, or a rotator cuff tear, or arthritis. We need to consider a mechanical joint derangement as its own diagnosis. And when you do that, you do find, well, I find 70 to 80% of patients' complaints are mechanical joint derangements. We first need to find the affected joint, however. Like I said, in the shoulder, a lot of shoulder complaints are because the neck and or the mid-back are not moving well. So we need to firm up the location of the disorder first, and then decide, is this something that will respond to movement in a specific direction done repeatedly, relatively simply? I didn't need help treating my shoulder. I could provide overpressure when needed, pushing up the back, pushing across the body, for example. But again, I think this case highlights, one, that acute and or semi-recent forces can put loads on joints, and they can cause problems. And if you're not thinking about joints as a possible problem area for a diagnosis, you're going to be diagnosing something else. Secondly, we typically don't need to keep on top of extremity joint derangements as much as we do with the spine. Third, it's interesting that you can present with obstruction without pain. I think that's usually a hallmark of a mechanical joint problem versus another type of problem. Certainly, it wouldn't be tissue, like I said, being tight, because the patient would perceive it doesn't go because I can feel that stretch. It's really tight tissue. So that's just a quick recap of a shoulder joint derangement. I still obviously see them and diagnose them in the clinic, but be sure to first rule out the spine.